Hello, everyone, and welcome again to this 43rd session of the International IVF Initiative entitled Back to Basics with a Twist. This session is very kindly sponsored by Hamilton Thorne. My name is Mina Alikani. I am the Senior Director of Northwell Health Fertility Laboratories in New York, and I have the pleasure today of co-moderating this session with Andrew Thomson, who is in Cardiff, Wales in the UK. Andrew is consultant clinical embryologist and the scientific lead at London Women's Clinic, Wales and Bristol. He is soon to be appointed to fellow status of the Royal College of Pathologists, which is the highest accolade available in the UK for reproductive scientists. Congratulations, Andrew. His current research interests include investigating the effects of cryopreservation on eggs and embryos and developing AI technologies for embryo selection. We are also happy to have Richard Slifkin as a panelist with us today. Rick graduated with a bachelor's degree in biology from NYU in 2006 and began his career in embryology that same year. He's currently the Embryology Associate Laboratory Director at RMA in New York, and he has a strong interest in PGT and performs over 4,000 trophectoderm biopsies each year. That's a lot of biopsies, Rick. Thank you for joining us, Rick. We have a great program planned for you today for the next 90 minutes or so. Please remember to ask questions. We have a talented team working behind the scenes to pose your questions to our speakers and panelists. But please remember to ask your questions using the Q&A section of the conference service and not on the chat function. Some questions will be answered live and others in the Q&A section. I now pass the virtual microphone to Andrew to introduce our first speaker. Of course, you can find the full bios of all of our speakers, moderators, and panelists on the I3 website. Andrew, please.
Thank you, Mina. Our first speaker is Dr. Alison Bartolucci. Alison is the Director of Laboratory Operations at the Center for Advanced Reproductive Sciences at the University of Connecticut. She started her embryology career in 1999 at Brigham and Women's Hospital in Boston. Alison obtained a Master of Science degree in clinical embryology and andrology from Eastern Virginia Medical School in 2005 and returned to EVMS almost 15 years later, where she received her PhD in clinical reproductive sciences in November 2019. We are very pleased to have her here today to speak to us on an area of her interest: Cumulus evaluation, oocyte competence, and miRNA.
Thank you, Andrew, and thank you to the entire I3 team for inviting me here today. So as you can see, we're starting off with the twist part of the webinar because my topic is Cumulus cells, oocyte competence, and microRNA, which is not something you see in an everyday IVF laboratory, but hopefully will offer a bit of a new perspective. So as Andrew sort of alluded to, a lot of the data that I'm going to share today is part of what I did for my PhD thesis through Eastern Virginia Medical School. And this was in collaboration with Dr. John Peluso at the Department of Cell Biology at UConn Health, and of course at the Center for Advanced Reproductive Services. So I think we've probably all used the term the Holy Grail when describing our quest for being able to identify embryos non-invasively that are chromosomally normal and have a high potential for making normal, healthy babies. We've certainly made some progress in this area with time-lapse microscopy, artificial intelligence applications, and of course, sampling the spent media for metabolites, protein expression, and even more recently, cell-free DNA for non-invasive PGT. But as part of this project, we actually wanted to take a few steps backwards and look at the level of the oocyte to see if there were any biomarkers that we could identify specifically for oocyte potential. When we think about the oocyte, one of the most obvious candidates for biomarker analysis is the elusive cumulus cells, not only because of their dynamic relationship with the oocyte itself, also because, as we all know, these cells are discarded as part of the routine IVF process, so therefore they're easily accessible. The relationship between the oocyte and the cumulus cells has only really recently been fully appreciated, and perhaps is not fully appreciated yet. While we once thought that the cumulus cells were merely a conduit for information to get to the oocyte, we now know that it's a much more complex relationship, and it's actually a bidirectional exchange of information. So the oocyte itself actually secretes oocyte secreting factors. This includes GDF9 and BMP15 that bind to receptors on the cumulus cells and then work to maintain the viability of the cumulus cells so that they in turn can do their function and allow for the transfer of things such as cyclic AMP and cyclic GMP to maintain meiotic arrest, as well as the transfer of metabolites and other substrates that work to ensure the proper development of the oocyte. But more recently, it has been shown that even larger molecules are transferred between the cumulus and the oocyte. And this includes RNAs and even a subcategory of RNAs called microRNAs, which I'm sure many of you have heard of. So microRNAs, as their name implies, are small, non-coding RNAs. They're about 20 nucleotides long. We'll try not to get too technical here, but they are synthesized in the nucleus as a double-stranded precursor molecule that is then transported into the cytoplasm, where it is spliced or cleaved into two single strands. One is typically just degraded, and then the other strand, and it's usually the 5' strand here, is incorporated into a binding complex that targets messenger RNA. And when it does this, it binds to it and blocks gene expression and translation. What's interesting about microRNA is that they are referred to as high-order regulators because they have the ability to bind to multiple targets because they don't require a perfect fit here. So the complementary strand of mRNA does not have to be a perfect match. So you can imagine that they have the ability to sort of target and bind to many different genes, and therefore have the ability to regulate and block the expression of many genes and ultimately cell function. So microRNA are present in almost all cells, and this includes the cumulus. MicroRNA 21, or affectionately miR21, is one of the most abundant microRNAs in human cumulus cells, although it has not been abundantly studied. It has, however, been studied more abundantly in other species. And in these studies, levels of miR21 in cumulus have positively correlated with oocyte quality and development. One study in particular in the mouse showed that those oocyte secreting factor GDF9 had a positive effect on the expression of miR21 in the cumulus, which led to a decrease in apoptosis in the cumulus. So this was an important study because it showed a causal relationship between expression of miR21 in the cumulus and the viability of the oocyte. Again, this has not been well studied in the human. So our hypothesis was that the expression of miR21 in human cumulus cells would correlate to the developmental potential of the oocyte. And just like in the mouse, we proposed that the oocyte secreting factors would bind to oocyte secreting factor receptors in the cumulus, which would lead to the synthesis of the miR21 precursor, and then ultimately the expression of the mature miR21. This would have a positive effect on Cumulus cell viability and ultimately the expression of putative oocyte survival factors. We also proposed that miR-21 would be transferred directly into the oocyte. And together, these processes would have a positive effect on oocyte maturation, fertilization, pre-implantation development, and even euploid blastocyst formation. So to look at this in the human, we collected individual cumulus cell masses from patients undergoing ICSI and PGT for aneuploidy screening. So we stripped these eggs in individual drops and then froze the denuded cumulus cells. The eggs were then tracked individually from there on out, ICSI'd and cultured according to protocol. And then embryos that reached the blastocyst stage or good quality blastocyst stage on day 5, 6, and there may have been a couple on day 7, were biopsied for aneuploidy screening. And once we got the results back, we then went back to the freezer and thawed cumulus cells that corresponded to oocytes that resulted in a rested embryo, an embryo that was aneuploid, and an embryo that was euploid. And we did this for each patient, so each patient had a representative of each of these categories. Then isolated the microRNA from each of the cumulus masses and performed qPCR for both the precursor forms and the mature single strands, the 3' strand and the 5' strand of miR-21. So these are our results. You can see while we actually did not see a difference in expression between cumulus cells from oocytes that resulted in aneuploid compared to euploid blastocysts, when we looked at all blastocysts, we did see a significant increase in expression of both the precursor and the 5' strand of miR-21 in cumulus cells that resulted in, correlated with oocytes that ended up becoming blastocysts. So we wanted to investigate further what miR-21 was doing in the cumulus cells to have this effect. So to do that, we then collected different groups of cumulus cells. This time was from all different patients, and we pooled them together. And we treated half of them with an inhibitor to miR-21. So it blocked the function of miR-21 in those cells. And then the other group was treated with a control. And what we found was that after 48 hours of culture, there were significantly higher percentages of apoptotic cells in the cells that had been treated with the inhibitor. So this was very much in line with what had been shown in the mouse as well. And also because we know that microRNA function to suppress gene expression, our next logical step was to look at these cells and look and compare the gene expression in these cells to see if we could identify some targets. So to do that, we used a PCR array and we compared the expression of 84 genes that were known to be related to apoptosis, but also known targets of miR-21-5P. So we compared the expression of cells treated with the inhibitor and those treated with the control. And although we actually didn't find, most of them did not show a difference, there was one gene, P10, which was significantly more expressed in the cells treated with the inhibitor. We did confirm these results used with qPCR and again found higher expression of P10 in the cells treated with the microRNA 21 inhibitor. So this was interesting and also was in line with our findings because P10 had been studied previously and its expression in Cumulus was shown to correlate with increased apoptosis and reduced oocyte viability. So in summary, the Cumulus cells that were associated with oocytes that developed into blastocysts had elevated levels of miR-21, and this suggested that it could possibly serve as a biomarker for oocyte developmental potential. This may be because low levels of miR-21 are due to insufficient levels of oocyte secreting factors from an oocyte that has reduced potential. And we know that low levels of miR-21 may alter the gene expression profile in Cumulus, leading to increased apoptosis, which would reduce the function of the Cumulus cells and then therefore further deplete the viability of the oocyte. But one question, and we did have many, but one question that plagued us was, how could this have an effect? How could this allow for normal development up until a certain stage? Why did it not affect the oocyte right away? Why were we not seeing this until the blastocyst stage? So to answer that question, we proposed the following theory, which will obviously need to be investigated further. But if we assume that miR-21 is transferred directly to the oocyte and the amount transferred is proportional to that found in the Cumulus, and we assume that this transfer is reduced or even terminated with expansion at the time of the LH surge when those junctions between the cells recede, then we can also assume that miR-21, the levels would ultimately degrade as the embryo develops. So if we assume these three things, we can imagine a situation where a quote normal oocyte would have a certain level of miR-21 that would be enough to suppress genes up until a certain point during development, perhaps even around the time of embryonic genome activation, let's say. So once these levels of miR-21 dipped below this threshold, the genes that it had been suppressing would now be expressed and would be required for proper blastocyst development. Where on the other hand, if you have an oocyte that has lower levels of miR-21, it's going to cross this threshold earlier, and the genes that it's suppressing will be expressed sooner and out of sync with embryonic genome activation, and this could result in arrested development. So in conclusion, future research on miR-21 will focus on the specific gene targets of miR-21 in the Cumulus cells and the pathways which they influence the developmental potential of the oocyte. We will also look at the mechanisms by which miR-21 is regulated in the Cumulus and transported to the oocyte, and the development of biomarker analysis using miR-21 5P to indicate developmental potential of oocytes for clinical applications. Thank you.
Thank you very much, Alison, for that very nice talk, and congratulations again on your PhD. I don't know how you juggled doing all this work with running a lab, a clinical lab, but you did it.
I'm not sure either.
Right. So there are a lot of questions for you, but we'll just pick up one question and address to you now and the rest later on. Don Rieger has a good question for you. How did you correct for the number of cells in the Cumulus mass?
So we did use, that was one of the first studies that we did, was we did count the cells so that we could roughly correlate when we had a mass of cells, how much we were using. And then we did, for the PCR, we did use a, like a housekeeping control as well. And also this was done within, it was done first within each patient, and then we compared the means across the three groups.
Right. So, and I said one question, but I'll sneak in another short one, which is, how do you see this playing a role in the routine IVF process?
Right.
How do you incorporate this into a routine IVF process?
Well, I mean, I think it's definitely too early to even suggest it, but I could see something like this being used for patients who are freezing eggs, whether it's for a donor egg bank or fertility preservation. I mean, right now we don't know much about what is going into the freezer. So if you had the ability to study the Cumulus cells in some capacity, whether it's for miR-21 or something else, and be able to give some sort of answers or some sort of insight into the eggs that were in the freezer, it might help to, for a patient doing fertility preservation, it may give her some guidance as to whether she should do another cycle, or for egg banks in terms of, maybe we only need to send 3 because these all look really good, or something like that.
Very good. Thank you so much. Thank you again.
Thank you.
Now, it's my pleasure to introduce our second speaker, Dr. Carlos Hernandez-Nieto. Carlos is a reproductive endocrinology and infertility specialist and Associate Director of Clinical Research at RMA of New York. He earned his medical doctorate at the University of San Luis Potosi in Mexico, completed his residency training at the Monterrey Institute of Technology and Higher Education School of Medicine, and he completed his clinical fellowship at the Mount Sinai Health System in New York City. His professional interests include fertility preservation, pre-implantation genetic testing, and reproductive genetics, among a few other topics. He's going to talk to us about slow developing embryos on day 7. Are they worth it? Thanks very much, Carlos, please.
Well, hello, everyone. Thank you, Mina, for the presentation. And first of all, I want to thank Gilles and the IVF Initiative for this great opportunity of presenting this day. My goal today is to share my insight on some research about day 7 embryos. I consider this presentation will alleviate most of your concerns regarding the clinical utility of these embryos. First of all, I have nothing to disclose. And let's talk about a little bit about embryo development. Multiple IVF milestones have shaped the history and the way in which we practice and handle human gametes and embryos now. These milestones include, amongst others, extended embryo culture, vitrification, and pre-implantation genetic testing. During extended culture, it has been established that the optimal embryo development in vitro reaches the full expansion or hatching on day 5 after insemination. This concept was supported by the recommendations from the Istanbul Consensus back in 2011, in which it was mentioned that embryos can be utilized for transfer on day 5, and slower embryos can be reassessed on day 6 to see if they were able to be cryopreserved in order to increase the number of releasable embryos. But some embryos takes more than 6 days to blastulate. Some days even require 7 days in culture to reach the blast stage. So previously, these subtype of embryos weren't considered for clinical use, and majority of centers routinely discard these embryos. But sometimes culturing these embryos another day will increase our odds of finding utilizable embryos, especially on PGT cases when trophectoderm biopsy is aimed to be performed. So it was commonly considered that day 7 embryos were slow growing and may be developmentally abnormal. And why are these embryos so slow? Well, some theories about the potential causes have been tested, as we can see here. These theories include factors related to gametes and as patient characteristics as well. Some other related to oocyte, sperm factors, embryogenomics, the structural components of the embryo, and of course, external factors related to the laboratory and the manipulation of embryos. But the truth to be told, all this has yet to be really fully understood. So why does these slow embryos have been discarded? Well, several studies analyzing fresh IVF outcomes back in the day suggested that the rate of development of this blast stage to the blast stage correlates with cycle outcomes. And the first reports to evaluate the transfer of day 7 embryos showed that these embryos to be suboptimal and resulted in poor implantation rates. But these studies had a lasting impression because as for years, they have negatively influenced the clinical perception against routinely culturing embryos beyond the day 6 of development. Recently, there has been a change in that perception as increasing in number of centers are reevaluating the clinical utility of these embryos. As you can see in this timeline, which showcases a brief history of development of modern embryo culture and IVF techniques, in which we start on the left back in the 80s with the first reports of culture to blastocyst stage, and we move all the way towards the modern day and the use of embryo extended culture. And it only took nearly 30 years when we can see here nearly 2010, when investigators really started to question what was the reproductive potential of these embryos. And a lot of data has been gathered until now. Here's this beautiful systematic review performed by Hammond et al., in which the authors condense all the evidence regarding day 7 embryos all the way to 2018. Here, they summarize the most up-to-date evidence regarding euploidy rates, implantation rates by utilizing the transfer of these embryos. As we can see here in these numbers, the rates of utilizable day 7 blasts has ranged from 2 to 8%. The rates of ploidy in these embryos when analyzed 25 to 37%. And they have shown during all this information that implantation rates could achieve from 19 to 56% and library rates around 11 to 42%. These are pretty good numbers. But important to mention that to date, majority of published evidence was based on a mixture of fresh and frozen embryo transfers, or included multiple embryos transfers, included studies based on outdated lab techniques, or didn't account important factors such as embryo quality, or even some of them utilize outdated PGT platforms. So what about the potential use of day 7 embryos on modern ART practices? And by modern ART practices, I mean that utilization of PGT and single euploid embryo transfers. And here I summarize the most up-to-date evidence regarding the euploidy rates of these embryos and the implantation. As we can see here on the euploidy rates table, multiple authors have now showed consistently acceptable euploidy rates when analyzing these embryos, which can range between 20 to 59%. And also the reports on implantation rates of these day 7 embryos have shown implantation rate between 18 to almost 56%. Yes, they are lower than when we compare these embryos against day 5 or day 6 embryos, but we still have pretty good numbers, especially for embryos that were historically discarded. So in our center, back in ancient times, we used to observe embryos on day 6 and ended up just until day 6. And we ended up biopsying some of them with poor quality. And we observed that some of them had lower survival rates and implantation rates. Then we observed that some of these embryos could reach a decent grading on day 7. And we decided to give them an opportunity, and we started having some live births. So at the moment, our center, we perform extended culture with sequential media. We perform assisted hatching with laser on day 3 of development. And then we observe embryos on day 5, day 6, or even day 7 to see when do they reach or they are expanded enough to be biopsied. So we have been doing this routinely with the day 7 included since 2012 for PGT cases. And with our available information, we wanted to answer this question: what is the reproductive potential of day 7 embryos? In our published study, as you can see here, our objective was to describe the embryonic ploidy rates per day of biopsy. And we wanted also to analyze the IVF outcomes after analyzing single euploid frozen embryo transfers. So we performed this retrospective analysis in which we observed overall that the majority of embryos that were biopsied at day 7 were more commonly found in patients that were at higher ages, as we can see here in this table, or patients that tend to have lower ovarian reserves. That's why they are showing more number of slow-growing embryos. When we analyze their entire IVF cycles, as we can see here, we saw that the majority of embryos were biopsied obviously on day 5 or day 6, but still we have a good number of day 7 embryos biopsied. And when we analyze their ploidy rates, we find out that yes, these embryos could reach an overall 40% euploidy rate, which is significantly lower than faster embryos. And then we parse the data by age, because we know age is one of the main drivers of ploidy in humans. And when we parse our data by the recommended age groups of the SART, as we can see in this color graph, we confirm that the euploidy rates are significantly lower on day 7s when compared with day 5 or 6 among all the age groups. We adjusted our analysis, of course, to control for important clinical and biological characteristics. We observed that day 7 embryos are significantly associated with greater odds of being aneuploid compared with faster ones. And we didn't stop there. We look at the patient cycle outcomes. We have described yet the biggest cohort date of day 7 single euploid embryo transfers to date. And we observed in a study that the overall implantation rate of 44%, we have a clinical pregnancy rate of them of 30% and a live birth rate of 21%. When we compare it, is lower against day 5 and day 6 embryos. Reassuringly, we also observed no differences or no significant differences on clinical loss rates, and neither differences on basic perinatal outcomes, as we can observe in this table. Furthermore, we performed this sub-analysis in which we assessed the embryonic quality of these day 7 embryos, and we observed that embryo morphology significantly correlates with cycle outcomes, as we can see here on the implantation rates. Of note, to date, in our center, we have performed around 300 day 7 elective single euploid embryo transfers, and we have been finding consistency among our results. Actually, our current data now suggests improved outcomes from our original publication in 2019. And then for this comparison of rates, we also adjusted for important covariates because we are dealing with retrospective data, and we found that there was a significant association with the use of day 7 embryos and lower success rates when comparing them against faster developing embryos. And thankfully, we found no association with pregnancy loss rates. So in our study, we concluded that these embryos will yield higher aneuploidy rates, but when they are found to be euploid, they represent a pretty acceptable implantation rate. However, it still remains standard practice to recommend to patients to transfer euploid day 5 or 6 first when they are available. Yet for a select number of patients who have only day 7 embryos, we suggest considering their use as they could lead to potential successful pregnancies. And that was our study. What's been published up to date or what's new? Our group at RMA of New York has been consistently analyzing data of these day 7 embryos. And during the last couple of years, we have presented on important meetings some studies. For example, I'm just gonna go fast through some of them. As we can see here, we also looked when we used to look for the embryos to perform the trophectoderm biopsy twice on day 6. And when we moved to just checking them once in the morning, on day 6, we found that there was no difference. As a matter of fact, we found more utilizable embryos on day 7 when we changed the practice to just looking at them on day 6 once. We have also looked for another different clinical questions. For example, we have found and we presented that the perinatal outcomes of these embryos are pretty comparable against day 6 or day 5s. And as other authors has also showed that. And we have also looked at factors associated with the success of these embryos. As I mentioned in a couple of slides ago, morphology is the best predictor of success. And furthermore, we have, at our lab, we have implemented or included the implementation of an algorithm-based embryo selection system that is prepared using multidimensional analysis of big data and deep learning techniques. In this algorithm that is normally being fed in real time with the outcomes of embryo transfers, and it calculates the odds of an embryo to implant based on the morphology gradings on their compartments. And we created this heat map you can see here, in which we can observe here on the right part that potentially some good quality day 7 embryos might outperform lower quality day 6 embryos. Still, this data has to be tested prospectively to really answer this question, but this is just food for thought. And not only our group, there are multiple groups, and I'm happy to see that other centers around the world are taking care and observing their data and sharing it with the community. And multiple other studies have shown that day 7 embryos might be worth implementing on a routine basis. So we have lots and lots of data. Now what we can do with all this? Thankfully, a group of scientists from San Rafael in Italy published their protocol to performing a meta-analysis assessing all these day 7 embryo data. And they recently presented their preliminary findings at ESRE this year, in which after analyzing almost 3,000 biopsy day 7 embryos and analyzing almost 500 euploid embryo transfers, their data suggested that day 7s are a viable option, and it will increase our possibility of improving our success rates. We still are waiting for this full information is published for good. So just to finalize, after the data I just presented very, very fast, are they worth it? And I think, first of all, we should ask our patients. It's not all about data, science, or numbers. The most important element on an IVF practice are the patients. We need to consider that they are doing impressive efforts to do IVF, and they want every single % of success to be on their side. So they want to achieve their dreams, and they have a lot of concerns and questions as well regarding these slow-growing embryos. As we can see, these examples I'm showing here in multiple or famous blogs and platforms. And if you go and ask them that if we should be giving these slow embryos a chance, they will give you a very, very important insight. For some of them, these embryos represent their last chance. So I just want to wrap up and finalize with this beautiful answer suggested by Dean Morbeck 3 years ago, in which the answer to is this blastocyst good enough to use may depend on circumstances, on the patient's circumstances, values, and resources as much as on the embryo itself. So after digesting all of this data, if you ask me if they are worth it, I will say that yes, they are worth it. So this is it for me. I want to thank again Giles for the invitation to participate today, and to the IVF initiative team. I also want to thank our panelists today, one of the coolest embryologists, Rick Slifkin, which of course I want to thank all of Impressive Embryology and all the members of our embryology team at RMA of New York, of course all of entire team of clinicians and people at RMA. And well, thank you. That will be it for me.
Thank you so much for an interesting talk, Carlos. And this is certainly a research area that's close to my heart. And I struggle to believe that there's still some clinics in the UK and Europe which don't even culture embryos to day 6, never mind day 7. And it's really interesting to see more clinics stretching it to day 7. And it's actually also worth noting that the first live birth from a cryopreserved blastocyst was frozen on day 7. So definitely worth it. It's interesting to see, though, that the euploidy rate with day 7 was lower. And when you compared the pregnancy and the live birth rate using the euploid day 7s, it was still lower than the day 5, day 6. And you mentioned it was single embryo transfer. Have you considered moving to double embryo transfer for the day 7s?
Well, it's a very interesting question. Here in the States, we follow pretty closely the ISRF guidelines for the embryo transfer. As you know, when we're dealing with euploid embryo transfers, the recommendation might be just to transfer a single one. That's why we have a big number of single embryo transfers. Yeah. One can argue that based on the lower implantation rates of these embryos, maybe it'd be worth it to transfer two, but that will depend totally on patient characteristics and prior history of failed cycles, whatever. But so far today, we are pretty adamant or pretty consistent of only transferring single euploid embryo transfers.
Great. So it's my pleasure now to introduce our third and last speaker, Dr. Anick De Vos. Anick is an ESHRE-certified clinical embryologist at the Centre for Reproductive Medicine in the Universitaire Ziekenhuis Brussels, Sorry for my pronunciations, Anick. She has been in the field since 1996, and she has a special interest in early embryonic development and pre-implantation genetic testing. And today she's going to talk about a very practical and relevant topic, multiple vitrification, warming and biopsy procedures on human embryos. Over to you, Anick.
So thank you for this introduction. I'm happy to be able to share with you our experience with multiple vitrification and biopsy procedures on human embryos. Let me start by saying that we have no conflict of interest and there has been no funding for this study. Pre-implantation genetic testing since a couple of years has shifted more and more towards trophectoderm biopsy at the blastocyst stage, day 5 or day 6, instead of day 3 cleavage stage blastomere biopsy, being more invasive to the embryos. PGD these days comes with modern diagnostic testing, such as SNP and NGS, and it involves blastocyst vitrification in order to allow time for diagnosis, and then afterwards healthy embryos can be replaced in an unstimulated endometrium. This new version of PGD sometimes comes with inconclusive failed diagnosis. Although the prevalence is low, 1 to 4% of the biopsies tested will have no diagnosis, and this represents a wastage of embryos. And for that, the only way to go is then retesting these blastocysts. But inevitably, this involves a second round of biopsy and a second round of vitrification. So far, we have limited data published on this issue, and especially at the obstetrical and perinatal outcomes, we are quite ignorant. In contrast to double biopsy, double vitrification, patients may also request PGT on their cryopreserved embryos. These embryos are unbiopsied, so this procedure will involve a single biopsy, although also 2 cryopreservation procedures. These embryos can be vitrified at the blastocyst stage or at the cleavage stage. In that case, an extra 2 days of culture will be needed to arrive in the blastocyst stage and allow trophectoderm biopsy. There are few studies so far on the effect of double vitrification warming, specifically on biopsy blastocysts, and it seems that there is no compromise for the clinical outcome. Anyhow, we started a retrospective single-center observational study in order to report on clinical and perinatal outcomes with human PGD blastocysts that were biopsied once, vitrified twice, or biopsied twice, vitrified twice. And the goal was to enlarge existing small data sets and to further motivate multi-center initiatives to collect data, especially at the level of neonatal follow-up. Our observation started in March 2015 and runs up till December 2019, with the follow-up of subsequent frozen embryo transfers until February 2020. The study includes 97 warming cycles, more in the double biopsy group than in the single biopsy group. In total, we have warmed 245 blastocysts. On average, per warming cycle, 4.4 in the single biopsy group, only 1.4 in the double biopsy retesting group. In total, 160 blastocysts were available for trophectoderm biopsy, and out of these, 160 were genetically transferable. We have rewarmed 51 of these, and as you can see, there are also still some embryos frozen for these patients. Survival of the cryopreservation is one step. However, being suitable for trophectoderm biopsy seems to be one step further, and the overall post-warming suitability for trophectoderm biopsy was 82%. This was higher for day 5 blastocysts than for day 6 blastocysts, although it was similar for blastocysts that had undergone already a biopsy or these that hadn't. The suitability, the post-warming suitability for trophectoderm biopsy in the case of cleavage stage embryos was far much lower, 37%. This is due to the fact that they need an extra 2 days of culture selection towards a good quality blastocyst in order to allow biopsy. Per warming cycle, biopsy rate was 84%, and out of the 160 blastocysts tested or retested, 48% were genetically suitable. This percentage was similar in the single biopsy group than in the double biopsy group. Survival after rewarming was high, over 95%. And this resulted in 45 frozen embryo transfers. Most of them were single embryo transfers. And we obtained a clinical pregnancy rate of 44% in the single biopsy group. This was higher than in the double biopsy group, 35%, however, not statistically different. The clinical pregnancy rate obtained in the single biopsy group was closer to what we obtained in our standard PGD practice in the same time period, 46%. When expressed per initial warming cycle, 30% of these warming cycles will end up in a clinical pregnancy group, in a clinical pregnancy in the single biopsy group. This percentage was much lower in case of a double biopsy, 11.5%. In total, we obtained 13 live-born singletons, 8 in the single biopsy group and 5 in the double biopsy group. And as far as neonatal outcome is concerned, an overall average gestational age of 273 days and an overall mean birth weight of 3,521 grams was obtained, not different between the single and the double biopsy group. We did not observe preterm birth. We did not observe low birth weight in this small series. Health outcomes beyond birth are very limited, as most of the children so far haven't reached the age of 2 years. However, with small data sets available, no major congenital malformations were observed, and psychomotor development did not show any specific problems. Of course, we intend to make this follow-up in the future. In 2020, we did not do PGD on cryopreserved embryos. However, we retested 46 blastocysts, failed diagnosis blastocysts, out of 63 warmed in 40 warming cycles. Of these, 33 were genetically transferable. We have warmed 13 of these, and we obtained 4 ongoing pregnancies so far, as to illustrate that data collection runs extremely slowly if single-centered, and even in a center as ours, performing on average 600 cycles on a yearly basis. So to wrap up our data, survival rates of rewarmed blastocysts are high, as reported in literature as well. However, suitability rate for biopsy is variable from 65 to 100%. It depends on blastocyst formation in the first place in case of non-biopsied cleavage stage embryos. Also, it depends on re-expansion and hatching, which is essential for trophectoderm biopsy, and that in turn might depend on the overall quality and specifically the trophectoderm quality of the blastocyst. To us, the rescue of failed diagnosis blastocyst seems worth the effort, since 48% of the embryos are genetically suitable. However, keeping in mind the lower efficiency with the double biopsied blastocysts, so the retesting blastocysts. So with double vitrification of single biopsy blastocysts, our data show that clinical outcome is not compromised. This has been published before on small or one larger series of frozen embryo transfers. With double vitrification and double biopsy, we obtained lower clinical pregnancy and live births, which is in line with two publications, Bradley and Neal, who also compared their double biopsy group with the single biopsy group. It is also in line with Pariego, who compared their double biopsy group with their standard PGD practice. There are two more publications who also compared the double biopsy group with the standard PGD practice, showing that blastocysts can tolerate a second round of biopsy without impairment of their competence. So there is still some controversy here, although it must be mentioned that a comparison with standard PGD holds the limitation that there has been no correction for age and blastocyst quality. As far as standard PGD is concerned, in literature, there are two publications on the obstetric outcome and neonatal follow-up with single biopsy, single vitrification. There is a follow-up on more than 1,700 children, showing that blastocyst biopsy may not add additional risk to neonatal outcomes when compared with the control group, which is very much reassuring. However, there is a study, a controlled study on pregnancies following trophectoderm biopsy, showing that there is a significant increase in preeclampsia associated with trophectoderm biopsy. So this certainly needs further investigation. There is an upcoming report on repeated cryopreservation, whereas it impairs embryo implantation potential. It does not seem to affect neonatal outcomes. However, this paper is focused on non-biopsy blastocysts, and one can imagine that an additional biopsy or even two biopsies may add some additional effects. So in the left panel, you can see the limited numbers of newborns so far following the double manipulation procedures. We have 18 children, reports on 18 children with single biopsy double vitrification, 30 in the double biopsy group, showing similar neonatal outcomes between groups and birth weights within the range of normalcy. These data are very important for and can help us today for proper counseling to couples, not only about their chances to have live birth, but also on the safety issue with these double manipulation procedures. I provide the audience with the citations that have been mentioned at the end of the presentation, and I'm thanking the audience for their attention.
Thank you so much, Anick, for that very nice talk. I'm not sure if I missed whether you mentioned how long you culture the blastocyst before rebiopsying after warming. Can you comment on that?
How long we culture the...
How long do you culture the blastocyst after warming before biopsying?
Not too long. I mean, we thaw in the morning, and it takes a couple of hours. That suppose we thaw at 8, we can do the biopsy around 9, 10 o'clock already. Unless there is no re-expansion of the blastocyst, then of course we have to wait. Occasionally we can take a second moment during the day. If that suits the diagnostic lab, then we would proceed at 1 or 2 o'clock. If then the blastocyst hasn't re-expanded and that happens, then we wait 1 more day. Of course, there it all depends on the initial vitrification of the blastocyst, whether it was a day 6 or a day 5. Which gives an extra day that we could, well, that makes a difference there. If it's already a day 6, I mean, waiting longer might end up in that the biopsy will not be feasible, that the embryo is not sufficient enough.
But do you set a limit on the quality as far as what you would, if a patient requests the biopsy of a poor quality embryo or an embryo with a poor quality trophectoderm, do you encourage or discourage it? Do you do it regardless of quality? How do you manage?
We are many embryologists to judge the embryos in our laboratory, but me personally, I'm quite strict with the criteria.
Right.
I mean, for me, it's all about the intrinsic quality of the blastocyst. The blastocyst has to show good quality, enough trophectoderm cells. So I also tend to wait one more day to let the trophectoderm grow and to have sufficient cells. But of course, it all depends on what you see within one cycle, because if there is only one blastocyst available, I mean, you can set your criteria a little bit more low and then, okay, go for the lesser quality blastocysts.
Right. So I think the discussion actually connects to Carlos's presentation as well. And I was just wondering whether this better performance of the day 7 blastocyst that you see, Carlos, over time isn't because you are pushing embryos, day 6 embryos that can be potentially biopsied on day 6 to day 7, since you have confidence in their development potential and you've gotten good results. So now you're pushing these blastocysts that could be biopsied on day 6 to day 7. And in effect, you are getting results that should be relatively comparable to day 6 embryos. I wondered about that. What do you think?
I think maybe Rick can jump in a little bit in here and explain a bit, but I think that, well, when we check the embryos on day 6 and they are not able or they are not expanded or had the grading to be biopsied, these embryos, we have seen that they are moving slowly, and that's because of something. We fully don't understand why these slow embryos or why they are moving that slow. We know that could be potentially, as we have seen that the aneuploid rates on them is higher, that potentially it has to do a little bit with the development and expansion of this embryo. But I don't know if Rick can elaborate a little bit on the specifics of what they look on day 6 and when do they think it's better to take these embryos one more day in culture.
Sure. If we're able to biopsy on day 6, which for us means there's some level of expansion in the embryo, and we grade on a modified Gardner's, it goes A to D. So we require at least a CC in order to biopsy. We have data that show D, our single-digit success rates, very low chance of pregnancy. So we require at least a CC to biopsy. So if there's no level of expansion where we really can't separate and physically biopsy the trophectoderm without potentially disrupting the ICM, or if the grade is a DICM or D trophectoderm, we'll push it to day 7. If it does meet that CC threshold, then we'll attempt to biopsy on day 6.
And are you doing any media changes, or are you doing single-step media? How are you doing it in the lab?
So we're sequential media. On day 3, we change over to a glucose-rich media, and we assisted hatch at the same time when we do that.
And no media change from day 5 or day 6 into day 7?
Correct.
Okay.
As a matter of fact, this year at ASRM, a group presented a big prospective trial assessing the refreshment on day 6, and they found out that those day 7 embryos did worse than the ones that weren't refreshed on day 6.
I mean, we use single-step media, so everything goes into the time lapse. So we will culture everything in the same media to day 7, but our euploidy rates with day 7 are probably somewhere between 10 and 15%. So It's just the comparing our system against people that do it a bit more routinely than us. Interesting.
Yeah, I wonder how comparable the results from the different laboratories are with respect to day 7 biopsy, because it really all depends on why you push to day 7 and what type of embryos you are biopsying. It's also very much, I suspect, as everything is age dependent. So it's hard for me to look at the meta-analysis that combines the data from such different practices and without a common theme or a standardized approach. It's very difficult to compare results across laboratories. Wouldn't you agree? Alison, what do you think?
Yeah, I agree. And I was actually thinking while you were speaking is, I wonder if the day of biopsy is not what's relevant. It's more the degree of expansion. You mentioned that what did the embryos look like on day 6? So if they were an early blast on day 6 and you could biopsy them, does that have any impact on, I presume it wouldn't impact the euploidy rate, but would it affect would the implantation rate be better or worse?
Right.
Yeah.
Yeah. Well, I'm not sure if we have the answer to that question.
Right.
I have, Marianne, if you would be kind enough to show those few slides. I wanted to sort of direct this discussion toward the question of hatching, because of course we are practicing different methodologies when it comes to opening the zona pellucida for different purposes. And of course, all of us are now using the laser. And just as a reminder, I have this slide to show that the openings that we generate in with the use of the laser are very, very different in terms of dimensions and shape compared to the openings that we used to make with acidified thyroids. With the laser, these openings are elongated, and the width of the opening is dependent on how far into the embryo you go, how far past the inner zona you go, whereas the overall dimensions will be dependent on the pulse duration. So the next slide. So that was just to note that we are doing something that is very different from what we used to do when we used acidified thyroids to generate an opening in the zona pellucida. Then the question is, what is the purpose of the laser-assisted zona manipulation? So we all refer to the procedure as assisted hatching, but in fact, there are different purposes to that, to the procedure that we are using. If we are to assist hatching post-transfer in utero, the size of the opening is aimed to allow full escape of the embryo from the zona in utero. And in fact, that is why it's called assisted hatching. And in fact, that is precisely what happens when we test it in vitro. We know that when we generate a hole in the zona, the embryo will escape from that hole and not anywhere else, and the zona remains thick. This is typically applied on day 3 or day 4 of development, and the embryos are cultured then nowadays to day 5 for fresh transfer, or day 6 or 7 for freezing. So it's also applied following warming of frozen embryos or vitrified embryos for FET, typically while the embryo is still contracted or collapsed. The next slide will show another purpose of the use of the laser in zonal manipulation to collapse an expanded blastocyst prior to vitrification for better cryosurvival. So in this procedure, we would, I would think that at least that's how we perform it. We use a minimum pulse duration to cause the collapse. Whether or not this actually assists in hatching, I don't know. The next slide will show the manipulation of the zona or opening the zona to encourage trophectoderm herniation prior to trophectoderm biopsy. This is done on day 3 or day 4 of development, and the embryo again is placed back into culture until the day of biopsy. And the size of the opening is aimed really to allow herniation, but to discourage full escape, because in most situations, the full escape of the embryo from the zona may complicate the biopsy procedure and the handling of the blastocyst. Does it assist hatching post-transfer? Most likely, yes. The next slide is where we use the laser to open the zona at the time of biopsy. So in other words, on day 6, day 5, day 6, or day 7. And the size of this opening is aimed to allow extraction or aspiration of 5 or 6 trophectoderm cells. And does it help hatching post-transfer? Well, perhaps. So, you know, I wanted to, we can now, I think you can end the slideshow, Marianne. Thank you very much. And I just wanted to put this out there and let everybody share their experiences and their thoughts on the use of the laser for zona manipulation and how they practice this methodology.
I find it such an interesting topic. In the UK, we obviously are a lot more regulated. We have the HFEA, who have this traffic light system, and assisted hatching is considered an add-on, and it's red lighted, and we shouldn't be doing it, and there's no evidence for it. But that all sort of changes when we move to PGT, because we have to do the assisted hatching to actually do the biopsy. Now, it's really interesting to see, I think every one of you said you do the hatching on day 3 or day 4. We don't actually do it in our lab until the point of doing the biopsy. And that's simply because historically we did it in day 3. We did it in the cleavage media before we hatched it in there, then moved it to the fresh blastocyst media. And then we were able to biopsy straight away on day 5. When time-lapse was then introduced, you know, the manuals for the time-lapse system said, we do not know the effect of lasering in the dishes. So then it was a case of we were moving the embryos into new dishes, the time and the witnessing and the expense of all of that, to then hatch it on day 3 or even day 4. So we moved, you know, from doing this day 3 cleavage into just a pure hatching dish. And then why are we doing this? Because we're essentially making biopsy dishes. So we moved it onto day 5 and doing it at the point of biopsy. And we actually found we got better quality blastocysts. So whether because the zona was still intact and it was able to contain the embryo even more and prevent, you know, this premature herniation, the trophectoderm was then able to proliferate even better to sort of build the pressure to then hatch naturally. It's just a case of, it's really interesting to see the different practice compared to how our practice has evolved over the year.
Right. Anick, would you like to comment on that? What is your experience?
Yes, sure, I would like to. I must say that we have a kind of Belgian compromise. We hatch on day 4 instead of 5 or day 3. Initially, when we started with trophectoderm biopsy, that was back in 2014, we started off with day 5 hatching, but we had the experience that we had to wait more before we could start to biopsy, because it all depends on how expanded and how dense, how large the tension is in the blastocyst, because if it is very large, I mean, as soon as you open the zona, it might be that the blastocyst collapses. Then you have to wait before it re-expands to start to see the inner cell mass again. So we were losing time there. And one other thing was, if the tension was not sufficient enough, I mean, you could make an opening in the zona pellucida, but the blastocyst will not herniate immediately. So we had to wait again. And that's why we changed the strategy. But at that time, we were still doing a lot of day 3 biopsy. And in order just not to confuse these two things, biopsying on day 3 or on day 5, we choose an in-between option, day 4. But we could as well hatch on day 3. I must also say that for day 5 biopsy, the size of the openings that we make are slightly smaller than what we make on day 3. We have always been blamed that we make our openings too large, but that is also because we want to be careful. I mean, you have to leave the zona as much as it is there as a protective shell for the embryo. But of course, the smaller the opening is, there is a risk that the embryo gets trapped in the opening. And that's also a risk I think we should avoid.
Yeah, exactly. And I don't think that those details have been fully worked out or standardized, honestly. This difference between the laser ablation size for assisted hatching for prior to transfer versus the ablation size for the purpose of, encouraging herniation for biopsy. Please jump in, anyone who would like to share your experience, either Rick or Alison, if you like to tell us your experiences.
We currently do biopsy, the hatching in the afternoon of day 3. So we like to see a little bit of compaction before, but I totally agree. The way to go is day 5. So we're currently, training ourselves and working to get to that point, because it just, the more we see, the more we read, the more we even look at our own embryos, it seems to be the way to go, is to just leave them. And if you can leave them in the dish, we use one-step media, why take them out one more day, one more time? Yeah. So although that's what we're doing now, our goal is to get to hatching on the day of the biopsy.
Yeah, it's very interesting. There is a stark difference between embryos that have been hatched on day 3 versus the ones that have an intact zona. It appears, at least, I don't think this has been studied well enough, but it appears that the ones that have not been hatched and have an intact zona have more cells. On the other hand, actually, I would have wished for Tom Huang to be here, because he's looked at expansion and with or without the assisted hatching. And he tells me that the total volume is very much the same, whether there is a breach in the zona or not. But certainly they look very different.
Well,
Rick,
even to that point, from a very practical perspective, it's harder to grade the embryos after they're, when they're herniating out of the hole. And, some embryologists will call it an expanding blast. Well, it's really expanding because you put a huge hole in it on day 3. It's not really, if you look at it, it's more, it's earlier based on the cells. So.
Right.
We,
yeah.
Sure, yeah. What we find is just the ease of doing a biopsy when you breach the zona on day 3 it's just so much quicker to biopsy off some cells. You have zona collapse is a potential issue when you breach the zona right before biopsy, and you have the issue, as Nick said, where sometimes you're collapsing it, and if you're not quick enough on it, the trove can very quickly surround the ICM, and then you need to wait for some level of expansion. Or you may have the opposite problem where it's difficult to separate the cells away from the zona, and when you breach the zona on day 3 and wait for it to herniate out, you just don't have those issues. I guess on the converse, on the flip side of that coin, you might have the ICM hatching out, and then you have to deal with that. But I do agree that you have the big advantage when you hatch right before biopsy, in that you don't have the entire embryo coming out, and we do see decreased thaw survival rates with completely hatched blasts. So that's another factor that we take into account. What we haven't seen is a difference in blastulation rate between hatching and not hatching. So we have data on that show they're very similar.
Yes.
But it depends on the size of the hole.
Yeah, I agree. And just to throw another wrench in there, where, if you're using the flick method to biopsy, it seems that that need for the herniation is obviated, because you can effectively grab without risking the collapse of the zona on the embryo. You can effectively grab a few cells and mechanically, with the use of maybe 1 or 2 laser pulses, just separate the biopsy. So it will be interesting in the next couple of years to see more data on that technique and see whether that truly, obviates the need for doing assisted hatching on day 3 or 4. Well, this has been a fantastic discussion. There are quite a lot of questions from the audience, and we'll try to answer these questions in due course. I'm going to hand the microphone to Andrew to conclude our session, since we are already at 4:20. So
bear with me. So a big thank you for everybody for taking the time to participate in the session and this discussion. I'd particularly like to thank our 3 speakers, Alison Bartolucci, Carlos Hernandez-Nieto, and Anick De Vos, for their excellent presentations. A big thank you to my co-moderator, Mina Alikani, and our panelist, Richard Slifkin. We would also like to thank Hamilton Thorne for sponsoring this session. Thank you to the organising committee of this initiative, Peter Nash, Jacques Cohen, Thomas Elliott, Scheista Sadrudin, Marianne Cervantes, and Giles Palmer for their continued efforts to organise and run these highly successful I3 sessions. There is a tremendous amount of work that goes on behind the scenes, and thank you for the huge amount of time you spend on this endeavour. Also, one of the more complicated elements of these webinars is the stream of questions and the way this is triaged by I3. Today's team members were Peter Nash, Giles Palmer, Anna McLaughlin, and Scheista Sadrudin. This session and the presentations will be available online soon, and we also thank Thomas Elliott for his superb technical skills in arranging these sessions. Tune in next Tuesday for another exciting cutting edge session, 44, sponsored by Embryo Tools and the Nadia Clinic, Ukraine, which is entitled Reboot, Cytoplasmic manipulation for IVF failure. So we'll see you all then. Please stay safe, and obviously to continue the conversation on, say, LinkedIn, Twitter, things like that. I'm sure we'll all be happy to have questions and continue the discussion.
Thank you so much. Thank you, everybody.